Hello and welcome to this webinar on restoring elective care services, where we'll be talking about restoring elective care services in the context of using demand and capacity modeling. Just to introduce myself, my name's Keith Khunpha. I'm the technical lead for the demand and capacity program, and with me is Ricky McCullough.
Hi, I'm Ricky McCullough. I work for the Elective Care Improvement Support Team. Nice to see you all.
Grand. So before we go into the nuts and bolts of looking at the restoration of elective services as a whole, we'll just go very quickly into the service level demand and capacity modeling, just to provide some context into how this is actually being used in the context of the greater planning process. So when I talk about service level modeling, what we're really talking about is detailed, operationally focused modeling at a very granular level. So within a service pathway, quite often at a very specific process level. And by modeling at this sort of level, we can use them as building blocks, these models, for less granular modeling. So we can aggregate these different models together to get a view of a whole service pathway and look at potentially at a trust level or even at a system level. So we've covered the fundamentals of this kind of modeling in some other webinars that we've produced, which can be accessed via the link that you can see here. And the key thing to note with this is that this kind of modeling, while useful in itself for operational modeling, is not the endpoint when it comes to service recovery planning, because that gives you information. It's what you do with that information, which is a really important thing, which is what Ricky will be talking about very shortly. In terms of what we've actually done to the core model to bring it in line with the situation for post-COVID planning, we've made some additions to the model. So what we can see here is a screenshot of a section that allows us to adjust the demand to account for certain factors that will have affected your demand, for example. So we know that there have been pauses in elective care, and you can see that in the form of this reduced level of demand. After the elective care pause, after we've actually reopened services, there's a transition where we expect demand to increase. And in the first instance, our expectation is that returns to some form of demand that's similar to historical baseline levels. And on top of that, we would be adding things like the patients that haven't necessarily been referred because they were not accessing, for example, primary care services, but still would need to be seen. So there's almost this extra lump of or hump of demand that we might expect to see to come through. So we can quantify that to some extent. This model will do that, and we can see how that might be spread across the following weeks thereafter. So that's one of the changes that we've made. The other aspect, of course, following on from demand, is capacity. So the model will also let you look at your capacity on a week-on-week basis for your various clinical sessions, and you can actually use the tool to look at how you might be accelerating the opening of your services and how that might match up, and if there is any potential risk to mismatch occurring. So the tool itself is available on Future NHS, and it's being updated on an ongoing basis. So if you do download the tool, do check back on a regular basis in order to see if anything has been updated. So that's the concept of the tool itself. In the context of how that's actually used, there's a PDSA cycle, of course. That's one of the core fundamentals in terms of the application of the model. So once you've understood the principles and the tools, you expect then to have an engagement with your operational colleagues, with your informatics colleagues, to decide how you're actually going to be implementing the modeling process. You start to populate the model and check if it actually matches service reality. And from there, if you're finding that there are differences, then that's the opportunity to analyze why and to use that as a driver for improving your local processes. And if it does match your service reality, then that can be used for your operational planning. Now, previously, that would be something that you'd be doing in line with your operational tempo, so potentially weekly or monthly, depending on when you were having your local performance meetings and things like that. Of course, with the current circumstances, things have changed quite a lot since. So this is something that we'd be encouraging to be taking place on a really regular basis, so weekly, for example. So once we've actually got a model that we are reasonably comfortable with in terms of its outputs, there's some follow-up questions to consider, really. And this is where it really links in with how you're actually going to be applying it to help your service recover from the impact of COVID-19. So here's just some starter questions to begin with. How do we know if we're doing the modeling well? How can we evaluate objectively if we're actually carrying out the modeling and we're actually doing it in a manner that can provide assurance that we've got something that's giving good output? Secondly, how can we use the information from the model to support our planning? So we've got this data about the potential gaps between capacity and required demand. How does that actually filter in to our service planning? And then how can we also use the modeling to mitigate risks in the service? So obviously there's a lot of additional risk to patients coming through because of delays, etc. So how can we actually use the modeling in ways that will allow us to intelligently plan ahead for risks to patients so that they're actually accessing care in a safe manner? So I'll be handing over to Ricky at this point, who will talk us through some of the questions, the answers to these questions that we've just posed.
Thanks, Keith. That's a really helpful overview of changes that you've made to the model, which is an ongoing process. And I think it really helps to make it an operational planning tool, which is meaningful on a sort of week-to-week basis. So that's really good. So we're going to speak about some of the recovery principles now from a practical perspective. So I'm Ricky McCullough, as I mentioned, from the Elective IST, and we're a group of managers who work across the country supporting organisations around elective care programmes and initiatives. We have 8 core areas of expertise, including reports and information, demand and capacity, leadership and governance, and pathway design and redesign, which kind of touch on some of the notions that I'm going to talk about today. So first things first. So we are in unprecedented times. And although we may previously have been used to having some known unknowns, we're very much in a position of unknown unknowns now, and we do not know what the future is going to hold, and it's leaving us feeling quite vulnerable and on the back foot. So what do we need to think about in terms of elective care recovery principles, particularly in the wake of COVID-19? So the main thing that we really believe that we need to think about is the operational management of risk, and that is about ensuring that patients are not coming to or have minimized potential of coming to clinical harm. And we've got some thoughts around clinical prioritization, and we'll talk about them in a bit. How we might practically go about demand and capacity planning, knowing that there's been disruptions both to the demand coming in and the capacity we're able to provide. What measurements and key performance indicators we might put in place to understand the impact of actions that we're making and if we're allocating our resources in the correct manner. Some thoughts around the ongoing validation of waiting lists, which is something many of us will be familiar with, the clinical review and clinical harm, the PTL, so the patient tracking list meeting. What are some good practice elements of making sure that we sweat this meeting as much as we're able to and we get the deliverables we expect? And then more strategically, last but not least, is the elective governance arrangement for supporting recovery. So those are some of our thoughts in relation to the operational considerations now. So we're going to think about operational management of risk. So as I mentioned earlier, the primary risk to elective pathways is the potential for clinical harm to our patients. And this is including, but not limited to, patients lost to escalation, patients who may be lost to follow-ups, or patients who have been on the waiting list for such a long time that they incur clinical harm to themselves. Okay, so what are the main touch points that we need to consider in terms of operational management of risk? Well, right at the beginning of the pathway, we've got the potential for appointment slot issues, or ASIs. And these are requests which are made primarily by GPs for elective care services, secondary care services. And due to the fact that we don't have the capacity needed within the time that we expect, it becomes an appointment slot issue. So we need to ensure that we're spending as much of our clinical resource as is appropriate actually reviewing those pathways which are coming in, so we can stratify the patients in a manner which suggests whether any of them are in a high risk cohort. Okay. We also need to think about our planned waiting list and our follow-up waiting lists. So these will not be active pathways. For a planned waiting list, this might be an endoscopy, and for a follow-up waiting list, this might be post-clock stop or active monitoring. The important thing to note about these patients is they have had a recognized clinical indication made, and they need to be brought back to see whether or not we need to do any further interventions. And this is particularly important when we might be dealing with something like post-cancer patients. So we need to make sure that we're monitoring those lists. We do have PTLs in place, a patient tracking list in place, and any patient who passes their due date is subject to clinical review. And a similar concept goes for active monitoring and surveillance pathways. We've got patients who did not attend. We need to understand why they didn't attend and clinically review those referrals so we know whether the patient needs to be brought back or not. We've got cancellations and deferrals. So when I say deferrals, I'm talking specifically about clinical interventions which haven't happened and the patient hasn't been subsequently discharged or reappointed. So the risk there is the patient will stay in a deferred status until someone actually comes and looks at that particular record on the PTL, and that might not happen for some time. So we need to have mechanisms for looking at cancellations and deferrals, whether they be hospital or patient initiated, and non-outcomed activity. So we need to make sure that every clinical or administrative event is recorded in our PAS system, so that when we do come to validate and clinically review, we have all the information at our disposal to be able to make the right call for the patient. So those are some of the thoughts around the operational management of risk. Okay, demand and capacity modeling. So we've got a task ahead of us in attempting to understand at what point our demand normalizes, if it does normalize at historic averages, and if any of those patients who may have been referred will no longer come into the system. So there are going to be questions that we want answered quickly about the baseline setting, and there'll be questions which will inform our planning strategy going forward. So around that, we've devised this low and medium high intensity scale around the approach to demand and capacity planning. So a low intensity is tactical. It should be a short turnaround time, 1 to 2 weeks, minimal analytical support needed. Generally speaking, the outputs will give you capacity needed and sustainable waiting list size, and the accuracy range is immediate baseline setting. For medium intensity, we expect that would take somewhere closer to 2 weeks to a month. You would need some sort of recurrent analytical support, and those outputs would include scenario planning. So we can have a think about how we might deploy our resources based on a number of variables, including the independent sector. And then high intensity is generally a significantly more involved endeavor. That might take month to turn around with dedicated analytical support, but that would give us some long-term sustainability planning and would inform conversations about how we deploy our workforce and how many whole-time equivalents that we need. So that's our current thinking in terms of setting a baseline around the modeling intensity. And there's a supporting slide here, which will be in your slide pack, which would indicate the level of granularity needed at each stage of the modeling process. So that's there for you to rehearse when you begin having conversations about the intensity level that you want to model at. We've also developed a scored assurance system, so a key lines of inquiry / scored assurance system. This chops up the model into its 5 components and essentially lays out some key lines of inquiry around the demand tab, around the capacity tab, around the parameters tab, and around the waiting list tab if you're dealing with first outpatients. And then we've got a scoring system aligned to the low, medium, and high intensity so that we can have an understanding of the quality of the modeling that's been undertaken. And the quality of the modeling that's been undertaken is very important because we need to understand what type of decisions can be made based off that completed modeling. Okay, so once again, a complete scoring system there with key lines of inquiry, which is available for you to test the outputs in conjunction with your operational lead and your clinical lead. And the expectation will be at the end of this process, you would have a summary scorecard, which would be fit for purpose following due diligence to play back to the senior management via your access forums to have a meaningful conversation about resources, resource allocation, and how we might go around thinking about changes to the pathway and the design of the pathway to mitigate some of our constraints. And some of your thinking around that might be things done in the community setting, for example, or the independent sector. Okay, so that is a very thorough back end to the actual modeling process. Okay, we need to think about measurement and KPIs. So how do we know, A, where we are from a headline indicator perspective, and B, whether the actions that we're taking are impacting our systems in the way that we might expect. So once again, we're in unprecedented territory now, and we're going to have to do some testing of our services to see what works versus what doesn't work. We currently have that articulated in a 3-tier system. So organizational oversight would be for senior management teams and operational leads to understand at headline level what parts of the service might need a deeper level of interrogation. And there's a second layer of KPIs around the more operational management of the service, and then a third tier of KPIs around the administrative functions. So those would be department-specific dashboards, such as radiology, such as theatres, such as endoscopy, such as your booking services, both inpatient and outpatient. So our current thinking has no more than about 10 KPIs in each of those sections because we need to keep it relatively concise. So some examples of headline or oversight measures. So at the highest level, what things might you be looking at to understand whether or not your system is behaving in the manner that you expect? Well, there's 10 of those on the screen, and you'll be able to interrogate those when you have the slides. We generally advocate, where it's appropriate, the SPC, Statistical Process Control System. SPC gives us some upper and lower control limits based on the data set that we've put in, and indicates the difference between special cause variation and common cause variation. Okay, and it's really the special cause variation that we want to focus on. So we want to take our thinking from a long list of things to scrutinize to a short list of things to action. Okay, so there's interdependencies at the KPI level, and they tell a story about the service. What you're looking at on the screen at the moment is 4 SPC charts which denote the national elective picture. Okay, so you can see here, top left, elective, general and acute ordinary admissions. That has an instance of a special cause variation, so orange special cause variation in January 18. And for those of us who are operational at the time, one of the things it will recognise is that was a point where NHSI asked us to cease bringing patients in, admitting patients. So the SPC methodology is quite cleanly caught that as something which was statistically significant, even when the volumes are very high. So top right, GP referrals made to general and acute. One instance of special cause variation there at around December, and we will recognise that is the Christmas period. Okay, bottom left, non-elective admissions, no change to your non-elective admissions because urgent services never stop. And total PTL on the bottom right, you can see a significant increase around April 18, and that was when a large London acute trust came back online from an RTT reporting perspective at the beginning of the financial year. So we need to find the interdependencies that tell the story about our service. Okay, we've got some thoughts there about the validation of waiting lists, and the principle that exists is all active waiting list entries should be routinely validated to ensure all clinical and administrative events have been captured and represent an accurate operational view of the patient's waiting time and status. And there's some bullets there about particular validation cohorts of patients you might want to be thinking about, in addition to some example lists which articulate how you might stratify your PTL from a validation perspective, but also which team would benefit from doing that validation, so that we know that the validation team is a tactical resource, so we should get other groups involved where it's operationally appropriate and they're trained to be able to undertake that task. We've got some thoughts around clinical prioritization. So capacity constraints at all stages of the pathway mean that clinical review of patients on the PTL is crucial to identify high-risk patients. And there's a link there to the Royal College of Surgeon guidance. And there's also some definitions around how we might go about cohorting that patient to understand the impact of that clinical risk. And these are some thoughts around how you might go about implementing your clinical prioritization locally and ensuring that you have clinical harm review mechanisms in place when you have indicated that a patient may be at the risk of clinical harm. We've got some thoughts around your patient tracking list, your PTL, be it your corporate PTL or your local PTL. There's some bullets here which help us to understand the way that we might characterize the PTL. So new patient splitted into admitted, not admitted, splitted into weeks, wait, gate brackets, clinical review long waiters, and oversight of ASIs. We've got some principles there for planned patients, and we've got some principles there for capacity review for you to consider. Okay, and likewise for diagnostics. So some principles there around what you want to be looking at your PTL meeting to make sure that you're getting the most out of it. The most key element is that actions need to be recorded, circulated immediately following the meeting, and then reviewed at the beginning of the next meeting. Okay, that's absolutely key. Okay, last but not least, we've got our governance. So what do we mean when we say governance? Well, elective care governance is the establishment of processes and policies which inform the organisational goals and continuous monitoring of their proper implementation to achieve said goals. And I think our primary goal in any healthcare setting is to ensure that our patients are getting their clinical interventions and treatments as soon as clinically appropriate, and everything should be shaped around that. Robust governance identifies the relevant actions and escalations which need to be taken through the organisation and mobilises information to travel through the organisation, both vertically and horizontally, for prompt scrutiny and resolution. Okay, governance clearly identifies the roles and responsibilities of teams and individuals via terms of reference and other supporting documentation, and helps us to understand what the deliverables are and who is responsible from an accountability perspective for delivering those. And what you can see on the screen now is an example RTT recovery governance structure. And I'd just like to point out that each of the subgroups, of which one is capacity and planning, were chaired by an executive at this particular trust. There was an RTT steering group chaired by the COO, and the RTT program board was chaired by the CEO of this organisation. So we need to have a clear understanding of what the work streams are, what the 5 key deliverables are for those work streams, and when those deliverables are not being achieved, there needs to be actions and escalations into the higher part of the governance structure itself. So those are some of the thoughts, practical, tactical, and strategic, around recovery planning from the experience of the IST. And I hope that's been helpful. And I'm going to hand back over to Keith now to close the presentation out.
Thanks very much, Ricky. So one of the things I'll be talking about, just to round things up, is linking the recovery principles with demand and capacity modeling. So one of the things that we've seen is that demand and capacity modeling isn't something that you do in isolation. Demand and capacity modeling is one aspect where we're obviously gathering the information that's required. It does sit under a more general governance framework. And that really is key to successfully implementing change in your system so that you can actually effectively recover your service. Without the governance, there's not really the direction necessary or the organizational oomph, shall we say, to actually push through the changes that demand and capacity modeling will highlight as necessary. And the modeling itself needs to be linked with measurements of any KPIs that you need to be using to help ascertain whether or not your organization is going in the direction that you need to be traveling. So within this kind of governance framework, you've got your modeling, you've got your monitoring and KPIs. That helps you basically understand the situation so that you've got this narrative that tells you what's actually going on, and that will help inform the decisions that you then need to make to minimize the risk to your patients. And those decisions will then drive your operational management actions. So that will be things around a lot of the material that Ricky's just gone through around clinical prioritization, your waiting list management, your capacity management. But those can't really be well informed until you've actually built the building blocks, of which we can see here. So that's very much it from us. Thank you very much for watching. I hope it's been informative. And if you are interested in other material, do feel free to check out the other webinars that we have available on our site. Thank you very much.